Morning, kids. I forgot the dad joke that David told me this morning. So, I've wanted to do this presentation for a long time and then not wanted to do this presentation for a long time because it is not very interactive. Like, how do you get a patient who's in chronic pain and then have them show up and then talk about it? But I want us to think about I really want us to let's think about the language that we use with our patients. That's going to be my overriding concern. And I am by no means an expert in treating patients with chronic pain. I think Dry Creek is much better than than we are. So if you have lots of chronic pain patients, I think they're the go-to place for that. You're welcome. Yeah. But it gets me thinking about. We'll hope forward and back works because the slide thing didn't work, right? Ha! Cool. All right. Since I'm not a neurosurgeon, I don't have really a cool picture of the brain, so I picked this one. But, and I've given this presentation in several different ways, and then I want to invite you to my conversation with my patients when it comes to their pain. So you're going to hear pretty much just what I say to them. I'm going to clean it up, make it a little bit more medical for you guys. So this guy runs everything, right? And I want to change our perception today to understand that pain is a concept. And I want you to think about the fact that, I don't even know if I have that slide. Okay, yeah, I do, maybe. First question, and it's of the few questions that I actually have, does tissue damage equal pain? Yes, no? No, it doesn't. It doesn't. Pain is a construct driven by the CEO that tells us if it hurts. I need more caffeine this morning. It should be well caffeinated, right? So there's this just sort of 3 or 4 different pain education models that we use within the physical therapy side, and this biopsychosocial model. And these guys are the ones that are sort of putting it forth. Lorimer Moseley, he's got a great video on YouTube. It's called The Snake Bite. I'm going to tell you that story, but you should probably watch it because it is hilarious. Adrian Lowe, he's the guy from the U.S. He's from New Zealand. He's in the U.S. And then Butler, which is a well-known nerve guy in the States as well. So biopsychosocial model is sort of the one that everybody talks about. And then, if you're ever looking into the online groups, the biopsychosocial guys tell the rest of us PTs that we're lame and we don't know what we're doing because we're not using a biopsychosocial model. I'm like, well, they had surgery. I can tell what's wrong with their leg. Like, don't need to ask them if they feel like it hurts worse. So this actually is a patient. It just walked into the clinic just yesterday, and I know that he saw Tyler. So this 65-year-old male, I'm just guessing, that he's 65. I didn't really look, but he looked about that age. And he's like, oh yeah, I went to the doc and my hands were aching, so my sister made an appointment for me. So I went over to, and I think he said I went over to this other place, and they sent me to an orthopedic surgeon. He's like, I don't know why you're here. You should be worked up by a regular doctor. He's like, well, let's take an x-ray. He's like, dude, you've got 3 fractures in your cervical spine and they're not super stable. You need to go see a spine surgeon right away. He's like, oh, okay, but I should be followed up by my regular doctor. So this is a guy who's got a neck fracture, but still seems to be functioning with a little bit of hand pain, right? So he gets worked up by his regular physician, and he's like, so my doc's like, well, let's just get an MRI and a CT, and he's like, I'm on my way home, and they call me, they're like, we want you to go straight to the emergency room. Like, where are you closest? It's like Spanish. It's like, go to the emergency room. He's also got a subdural hematoma. Dr. Edwards sees him, and then and I think that's how they ended up over here, right? I don't even think he had that managed. He actually had another procedure done to clip it, right? But there's a guy who just walks in with a cervical fracture and a subdural hematoma because he's got a headache. Like, if I had either of those 2 things, I'd probably be, like, oh God, like something's wrong with me. I think because when we talk about just pain in general, we have this perception. There's one of these buttons, but I don't know which one it is, so I'll do that. we have this perception that it's supposed to be bad. And our perception of how bad it's supposed to be is driven by Dr. Google, right? And our next door neighbor and our buddy who had a shoulder surgery, or somebody who had had an ankle surgery, and they're like, oh, it's the worst pain I ever had in my entire life. Or it's the best pain I've ever had in my entire life. It was no big deal. And those two things drive a lot about how we feel about pain. And I'll share just a couple of stories about how that works. And maybe we'll have time at the end. It'd be great. So there's a whole long list of references. But so when we start over here, this is sort of our current pain model. And I know I'm driving him crazy because I'm moving around. Symptoms and pathology. So we have symptoms, we have pathology, and it's usually relatively linear. When we create an intervention, usually our symptoms start to dip down. The problem is that in 1 in 3 individuals in any course of action, 1 in 3 moves into this chronic pain cycle. And we're still trying to figure out why that 1 in 3 happened, right? So, and the biopsychosocial model says that like maybe it's our perception of pain, or maybe it's what we've learned about pain, or maybe it is our cultural norms around pain. So this is somebody getting ready to step on a nail, and this is from one of the 3 long weekend courses I took on pain. It's not going to hurt, generally speaking, if I step on something. This is because we don't know the nail's there, right? So we have this injury, and we can run into one of these 2 categories. This is the 1/3, right? Where they have an injury, they experience pain, no fear, they confront it and they recover. That's generally the way it's supposed to happen. Like I have this thing happen, I get it fixed, and then I recover, right? The problem is this 1/3 happens to fall over here with a pain catastrophe, negative affect, right? And now they just start having this pain-related fear, and they run in this cycle, and we're trying to figure out like how do we run these people out of the cycle? So part of this has to do with tissue injury in our neurology, our nervous system. Our neurons get overly excited. People say like, well, why do chronic, and you've seen these people with chronic pain, they come in and they just look terrible. And the slightest thing sets them off. You just like touch them and they're just like, oh, that's terrible. And you're like, geez, like how are you that painful? Well, part of it has to do with this. This is our normal resting level of pain, and this is where we start to fire a pain message. I already asked that question, right? It was 10 o'clock. Oh, now we're not moving. Amelia. I already asked the question earlier about this tissue pain. So if we have this situation, I'm waiting for the slide. There we go. Thank you. Are you going to have to sit? No, I'll do it. That's fine. I'm just messing with you. So this is the post-injury norm, right? And this is our normal level of attention. So they call it just neurology, right? Our normal attention level for pain is relatively low. But when you spin the system up, remember the brain is in charge of keeping us safe, and it's in charge of all of these decisions, right? There's 2 loops, one local spinal cord reflex and then all the way up to the brain. And either one of those can feed us the information about whether or not this situation hurts. Okay. There we go. The problem is, this is where we're supposed to be. This is called less extra sensitive. I don't really understand how that is, but if our neurology and our neurons, because we're in this constant pain state, decide that there's something we need to pay attention to, now it's going to add additional, and this can be anything from pain receptors that we're trying to block with opioids. The body's really great at that, by the way. We block a bunch of receptors, and it's like, oh, I'll just add more. And that has to get fixed, right? It doesn't get fixed by more opioids, by the way. I mean, it might if you opioid them into unconsciousness, right? Now we're sort of at this resting level where it doesn't take very much. Here it takes a lot of stimulus to get us to fire off a pain message. If we're resting up here to this extra sensitive level, not much stimulus, right? Which sort of explains the situation about why it is that people are in a lot of pain. Okay, we'll just put this here. All right, Dr. Lorimer Moseley. I love telling this story. I'm going to tell 2 stories, which is the basis of my of my conversation today because you're all going to pain class. Dr. Lorimer Moseley, he was in Australia. He's wearing a sarong. This is kind of true. That snake is kind of a cool adjunct to the story. So he's walking along, he's camping in the outback in, I think, Australia. I'm not good enough to tell between the two things. So he's walking along, going down to the lake to have a bath, and he feels this thing brush the outside of his leg. And his brain is like, what is that? And it's like, have I walked here before? Have I done this? Yeah, it's a twig. No big deal. Scrape my leg on a branch, just keep walking, right? Bathes, comes back out of the water, wakes up in the hospital. He's bitten by one of the most poisonous snakes in New Zealand, and they're like, holy crap, you survived. Interesting. More interesting is the fact that he was doing the same thing about 4 months later, walking along in the bush, same type of a situation, something hit the outside of his leg, and his brain went, hey, have we been here before? That's a snake bite. And he's rolling around on the ground because his leg is on fire and he can't move, right? Until one of his friends points out a simple fact. He's like, just a scratch, dude. What are you rolling around on the ground for? This is where the brain takes over. The brain assessed the situation and responded appropriately. Last time he got hit, similar situation, similar attire, similar place. It was a snake that bit him on the outside of the leg. This time, nothing. A slight little twig. But because the brain was in that alarm state, or at least when it came to contact to the outside of the leg in a similar situation, it made a decision for him and put him on the ground. All right. Now to a really cool story. This is one of my favorite stories. You'll see why in a minute. Do you guys know what a date palm is? Yeah, prevalent in Mexico. See them in California a lot. They're really pretty tree, especially when they grow up. They have these spikes. This doesn't do it justice. That's usually about 6 inches long. And when they're dried out, they're sharp and brittle. And so we had built this house right after, right after I got out of school. And we had an old date palm way back in the back corner. And they take like 50 years to grow tall, like a really long time. This thing was about 30 years old, but it had never been trimmed. So you see the date palms and they're all just like nice and clean and the little palm fronds at the top, right? And nope, okay. So that's what they look like. This is a date palm injury, by the way, because those spikes have a lot of something on the end of them. So we had a date palm that wasn't quite this tall, it was about that tall. I wanted to move it to the front yard. So the problem is you have to trim it all down. It's just nothing but foliage. So I'm just into the middle, trying not to get stabbed by one of these things, and my brain telling me like this is going to happen if I don't pay attention, right? And I'm chopping down, taking a chainsaw and wherever else so I can get the middle down so I can get in there, and then we're just dealing with the bottom that has just had this like 4 feet of foliage, like we're digging this hole. And I'm kicking I'm kicking the palm fronds out of the way, trying to just move it and cut it. And my wife is there and she's helping. I'm like, just be careful, we're doing this whole thing. And the whole time I'm telling myself, like, I gotta watch out where I'm kicking, because if I kick one of these stupid spikes, it's gonna go right through my boot, right? And I could get injured, or into my leg or anything else, right? And we're like 3-4 hours into this little project. And sure enough, I kick it. Shunk! Right into my boot. Right into my toe. Like I want you guys to feel this with me. I can feel that point, this point, that point, doing that to the end of the bone on my toe. And I fall down and I have to scoot backwards out of the hole. And I got this palm frond sticking, visual confirmation, it's sticking out of the edge of my boot. It's right there. And my wife's like, what can I do? And I'm like a strong man, I'm walking it off. No, I'm crawling, I'm holding my leg out straight, because every time I move my foot, it's just grinding on that bone. And I'm like, I don't know, like, get the pliers, I don't know, like, cut my leg off. I'm not really sure what's happening here. So my boys are like, Dad, are you okay? Like, you can see the image, right? The whole picture of this. Crawling up on the grass, I'm like, I don't know, just get pliers, just pull. I've got to get that thing out of there because I can't take it off my boot. It's pinned my shoe. Like this thing sucks. And And so she gets some pliers and she just pulls it out. And I'm like, oh, okay, so that's better. Like, I'm not there. I don't think so, right? Because it didn't break off. But I can feel the blood pooling in my boot. And I'm like, this is not going to be good. This is not going to be good. Okay, take my shoe off. I'm still on the ground. I'm like, my leg is just out straight, right? Take my boot off. Like, oh, maybe it's not that bad because there's no blood. Like, not a lot. Like, I thought it was like in my boot, like this whole just injury thing. And we take off the sock. And have you guys ever taken off your sock after you've sort of been wearing outside? What do your toes look like? Just a little bit wrinkly and pink with no hole in it? Nothing. Missed it. Didn't hit my foot at all. Not even a little bit. Nothing. Why? What was that? What was that nonsense? Why was I doing that? I had to hole punch my man card about 17 times and apologize to my kids because Daddy's such a baby crawling on the ground. Daddy, are you okay? I thought you hurt your foot. Holy crap, right? Yeah, no. So I say this is my favorite story. Why? Why did that happen? Why did Lorimer Moseley's leg go into pain and spasm and flip out when there wasn't a snake bite? And why did I have to crawl backwards on my grass with a spike sticking out of my shoe, knowing that it was sticking in the end of my bone? I could feel it. I could feel it grinding on the end of the bone, like up, like missed the nail. Like I knew exactly where this thing was. Nothing. Pink as a baby's foot. God, what a turd. How did I do that, right? I didn't. The answer is I didn't do that. My brain told me that's what was happening. And I kept feeding it enough information about the situation that was going to happen that it made it real. You want some good entertainment, go look at the rubber hand experiment on YouTube, right? Where they take a guy, they basically put him in, I was going to show it, but videos are hard to get, right? Where they put his arm around the outside of his board and they put a rubber hand in front of him and then they map. They rub a feather or a ruler, and the one that's my favorite one, a ruler, and they map to the rubber hand and his real hand. And they run the ruler where he can't see it. I'm just going to touch your finger with the ruler, and they map it over until he feels the sensation on the rubber hand. Taps it with a hammer, and his finger twitches off camera. And then he just starts doing it, and the guy feels it, and he smashes with a hammer. He's like, oh my God, it hurts like crazy. And he jumps up, and the rubber hand's still sitting there. Like, your brain will tell you that you have pain. So, as practitioners, where do we go with this? Been really good research showing that when patients come in to see the spine surgeon and they see a model of a disc that's fallen out of, you're like, oh, this is your disc. I want to show you the nucleus pulposus, right? That's it. My disc slipped. I know exactly what it is. Or the patient that comes in and tells you, I have a 3 millimeter disc bulge. This is why I'm in so much pain. I'm like, me too. I mean, we share private information. Tyler's seen my MRI. I got a 3 millimeter disc bulge. I don't care. I'm not gonna let that tell me what's wrong. Evidently, I'll let a palm frond tell me what to do, but for some reason I won't let my disc bulge, right? So part of our language has to be when we talk to patients about modulating these situations. How do we have a conversation with them that doesn't involve their anatomy, their injury, and how bad it's going to be? Instead, it has to be everybody responds differently. And there's a whole conversation that happens around this. Telling my story, I don't even know where I'm at. Cool. So,
sorry, something's wrong, and I wasn't able to do that.
Okay, thank you.
My pleasure.
Did you get that? Because that was awesome.
That was sarcastic.
Yeah, that was. She's a little snarky. I'm afraid to talk to her right now. So I went to USC for my doctorate degree, and the one thing they don't tell you, it's not in the brochure, there's the juvenile detention center that's right across the street from like where we park our cars, like literally. And like day one safety briefing at USC is like, so we want you, if you see anybody in an orange jumpsuit running down the hall, like don't try to apprehend him. We're like, what? Like it is really in the not nicest area of town. So how many of us have heard when we're just inside, outside a building or whatever, heard somebody's car alarm going off, right? And it's not the old car alarms like we used to have. It's like somebody just leaned on the panic button, right? That also is a noise for when somebody does this to your car and opens the door. Okay? Picture this. You're sitting in your apartment complex, in your house, whatever, and you hear a car alarm, deet, 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 going off, and you're like, oh, God, would they just get their keys out of their back pocket and turn their car off? Like, killing me, right? You didn't go to look, nothing, unless like it keeps going off and you want to see if it's your neighbor's car so you can call him and tell him to shut it off, right? That's our brain, this is what we're thinking, right? You heard it last night. In the morning, your neighbor knocks on the door. And you're like, hey, did you hear the car alarm go off? And you're like, oh, yeah, I did. He's like, yeah, somebody broke into my car and stole my laptop and my wallet. And you're like, jeez, I should have looked, right? Now, next time the car alarm goes off, what are you doing? You're going to go look, right? Because your brain has told you, because of your experience, your brain has now told you this is something you need to pay attention to. And this is the same as pain. If we have a painful experience, our brain decides to tell us that it's something we need to pay attention to. And then we become a lot more involved in talking about our pain and feeling our pain. Like, oh yeah, I can feel my SI start to shift right now. Like who does that, right? And we want to, I don't want to say villainize these people, but we want to just discount the conversation they bring into our clinic because they have a better ability to sense pain than the rest of us. Than our first guy who has got a cervical fracture and a hematoma and is like, he's got a subdural and he's like, I got a little headache, my hand's numb, and the rest of us are like, I'd be in a freaking wheelchair in the ER asking for Toradol, right? Or, I mean, certainly given the experience I shared, I'd probably be in the ER dragging one leg, right? Because I like to catastrophize things, evidently. All right. So, Lorimer Moseley, and so he did a study, I think 2002, and then Adrian Lowe reproduced the study, and they just did functional MRI. It was an N of 1. It's tough to get a lot of these people to kind of do these things. So this is what pain looks like on periaqueductal gray matter. So this is somebody who's in pain, right? And they did a functional MRI scan. Basically, patients with chronic low back pain for years, they were on opioids and morphine, and they asked them to do an abdominal contraction. And in the physical therapy world, we know that a transverse abdominis contraction is one of the hardest things we can get people to do because for some reason it's inhibited, even though when they do it, it doesn't seem to hurt their back. It can make things better. So part of the frustration is as PTs, can we get you to fire your TA in order to provide this belt of stability across the front, right? So that was the action, functional MRI, rest, fire your TA, right? Can we get them to do it? 1, and then 2, what does it look like on functional MRI? This is not the area for motor control, by the way, just in case you're curious, right? Neither is that. So we're asking for a motor activity that they report doesn't cause pain, yet we're having a lot of diffuse functional MRI activity all over the place. This makes no sense, but neither does chronic pain, right? There's motor cortex. It should be right in here, right? No activity in the motor cortex. Their brain is all over the place, sending lots of diffuse signals. Okay. Next one. So this is therapeutic neuroscience education. I think this was his first one. So this is after a conversation about pain. Where it comes from, how it is distributed, what is your alert level, how should you respond? Pre-conversation, post-conversation, same activity. Less diffuse, we could say less diffuse, but really not there, right? Cerebellum, that's not bad, post-education scan. Motor cortex, well, holy crap, it's in the right spot for finally, right? So now they're actually using their motor cortex to fire transverse abdominis after they have, it's called a post-education scan. I'm going to tell you what the education is, but that's not something. we're going to talk about. All right, so here's all three lined up. Here's original research. So box A up in the far corner, this was their brain pre-anything, no intervention. Right? Box B, this is just asking them to do a transverse abdominis contraction. Right? Box C is a week later, after they've spent a week, maybe 2 weeks. It's all down here in the fine print. I'll have to read it. A week, maybe 2 weeks after they've done this pain neuroscience education. Like, clear. It's where it needs to be. So the question really is, I love that. I should have lived with that one. You're having pain, like, false. Pain is what does it say? Experiencing simply electrical signals that are going to the brain, right? So pain neuroscience education, unfortunately, in their world, it's really like a 2.5, 3 hour conversation. It's not best done in the physical therapy setting, right? But if we have patients, and this would be maybe my admonition, is that if we see patients that are falling into the catastrophization cycle where they start to identify with their pain, maybe it's an opportunity to have a discussion with them about where pain comes from. Once again, Dry Creek is amazing at that. I wish Ben was here. He'd love that. Actually, most physical therapists these days are starting to get this pain neuroscience education as part of their program. It's a little rough to see students do it because I've had patients like, you're saying it's in my head. I'm like, I'm saying it's in everybody's head. I got to jump in and solve that problem, right? So we can provide an opportunity to have this conversation with our patients. But I think we have to realize that there's something else going on, right? If a patient comes in and tells me I have a really high pain tolerance, but everything hurts, oftentimes I find that it's the reverse. They don't really have as high of a pain tolerance as they might. The guy that came in with a cervical fracture and a subdural hematoma and tells me his hand aches a little bit, he's got a high pain tolerance because he's not talking about it, he's not thinking about it, he's not presenting about it. In my practice, I will tell you, I rarely ask people about pain. I just don't. I want to know what the function is. I want to know why it is they can't do what they want to do. I don't want to know how much it hurts. How much it hurts equals how many units of morphine. And Medicare only cares about that when you pay them that way, right? For me, I want function. What can I do? If your pain is limiting you from function, what can I do to alleviate your symptoms so that you can function better? That's what I'm interested in. That's what we're all interested in honestly, right? We just want to make people better at what they do. So, you've actually just attended my patient conversation when it comes to pain. And because you've listened to this and you've understood where pain comes from and how it's driven, your brain is more likely here when it comes to your pain than here. And I can do that in 30 minutes, 45 minutes. Mostly because they look at me differently, like you're the guy with the palm frong in your foot and you're crawling on the ground, right? And I'll ask them that question. I'm like, why? Why was my foot that way? Why did I have this problem? Why did the snake bite thing go that way? And they say, well, I guess maybe it's my perception of pain. And if we can get our patients to understand that pain is driven not necessarily by tissue damage and pathology, but driven by our sensation and our experiences and our beliefs around pain, then we can change, and hopefully we can move that number from 1 in 3 to 1 in 4. We'd probably save $1 billion in this country if we moved it from 1 in 4 to 1 in 3. 1 in 3 to 1 in 4. Well, that makes sense? All right. That's it. There's a boatload of references if you want it. You could ask me questions, but I'm not an expert again. Thank you, guys.